Picture your gastrointestinal tract not just as a collection of organs, but as this massive, continuous industrial facility. Honestly, it's a marvel of biological engineering. But for this facility to function, it requires two absolute non-negotiables: a massive, uninterrupted power supply, which is your blood flow, and perfectly clear pipes to move material through the assembly line. If either the power fails or the plumbing backs up, the entire factory shuts down, and the consequences can be downright catastrophic. Today, we're going to master exactly how and why this facility breaks down. We'll be focusing heavily on those critical, high-yield diagnostic points that are absolutely essential to understand for your board exams or anyone deep into human physiology. Let's jump right in.
So let's start with a real clinical scenario. What happened to John Quidley? John's a 55-year-old guy who suddenly comes in with severe abdominal pain and vomiting. He hasn't passed a stool in 4 days. But here is the absolute critical clue. John has a history of rheumatic mitral stenosis and atrial fibrillation. When doctors examined his abdomen, it was only mildly distended. A little tender, sure, but there was no severe rigidity. Yet his pain was agonizing. Okay, flag this, because it's a massive diagnostic buzzpoint. Pain completely out of proportion to the physical examination. What happened? His quivering heart formed a blood clot. That clot dislodged, shot down his aorta, and perfectly blocked his superior mesenteric artery. It instantly cut the power to his intestines.
So let's unpack this. What John experienced is ischemic bowel disease, specifically acute mesenteric ischemia, or AMI. Simply put, this is a syndrome caused by inadequate blood flow through the mesenteric vessels. It's a total critical failure of the facility's power supply. This almost exclusively hits patients over the age of 60, and it is a true medical emergency. Think about it. The intestinal mucosa has a remarkably high metabolic rate. It demands up to 35% of your total cardiac output when you're digesting a meal. If that flow just stops, the bowel wall literally starves. It leads to ischemia and eventually gangrene. Left untreated, the mortality rate is just staggering. To truly master this, we're going to follow a really logical roadmap. First, we'll look at what happens when that blood supply acutely and chronically fails. Second, we'll map out the highly vulnerable watershed areas of the colon. Third, we'll shift from the power supply to the literal plumbing and examine mechanical intestinal blockages. And finally, we'll explore functional intestinal obstruction, where the system is physically open but it just completely forgets how to work.
Starting with Part 1, when the blood supply fails and the power grid goes down.
Because the mucosa is so highly metabolically active, things go bad quickly. Within just 10 minutes of a blockage, cellular damage begins. By 30 minutes, it's extensive. It's a terrifying progression. The earliest damage happens at the very tips of the intestinal villi, causing what's called a mucosal infarct. Now, at this stage, if you can get blood flow restored, it's actually completely reversible. The mucosa can regenerate. But if that ischemia continues, it pushes deeper into the submucosa. That's a mural infarct. Finally, by 6 hours, the tissue suffers a transmural infarct, meaning the entire thickness of the bowel wall just dies. That is gangrene. When you see a surgical view of this, it is sharply demarcated, hemorrhagic, and this really distinct dusky purple color. At this transmural stage, the gut wall completely loses its integrity. Bacteria invade, the bowel dilates, and lethal peritonitis sets in. Now, how the power fails is just as important as the fact that it failed. We absolutely must distinguish between acute occlusion and chronic ischemia. Acute mesenteric arterial occlusion, like with our patient John, is sudden. It's usually an embolism, often from a cardiac thrombus due to AFib, that just abruptly cuts off the artery. The diagnostic gold standard: immediate CT angiography. On the flip side, chronic mesenteric ischemia is gradual. It's caused by diffuse atherosclerosis slowly narrowing those mesenteric arteries. Because it's so gradual, the body has time to form collateral blood vessels. The classic, incredibly high-yield presentation for chronic ischemia is intestinal angina. This is severe abdominal cramping that predictably starts about 30 minutes after eating. The gut suddenly demands more blood to digest, but those narrowed arteries just can't supply it. Because eating causes so much pain, these patients develop a literal fear of eating, called cytophobia, which leads to profound weight loss. So that covers the main arterial trunks. But what about the edges of the grid? Let's move to Section 2, the vulnerable watershed areas. Sometimes, there's no physical clot at all. If an ICU patient has a massive drop in blood pressure, the body panics. It clamps down on peripheral vessels just to save the brain and the heart. This generalized vasoconstriction starves the gut, causing what we call non-occlusive mesenteric ischemia, or NOMI. Now, mapping this out, the large intestine relies on branches from both the superior and inferior mesenteric arteries.
They're connected by a collateral pathway called the marginal artery of Drummond. But there are two distinct weak points in this collateral chain, the watershed areas. First, you've got Griffith's point at the splenic flexure, right where the superior and inferior territories meet. In some people, the connecting artery here is incredibly small. Then there's Sudek's point at the rectosigmoid junction, another really fragile junction of arterial branches. Because these spots are at the absolute furthest reaches of the blood supply, they are the very first to take the hit when blood pressure drops.
When hypoperfusion hits these specific watershed areas, it causes ischemic colitis. Note that this is distinct from the small bowel ischemia we were just talking about. Ischemic colitis typically strikes patients over 65 who have just survived a major cardiovascular event, like a heart attack or maybe major surgery with heavy fluid shifts. The hallmark clinical presentation, and you absolutely must memorize this for your exams, is left-sided cramping pain followed by the passage of bloody, loose stools. And unlike acute mesenteric ischemia, which usually needs a CT scan and immediate surgery, the gold standard for diagnosing ischemic colitis is actually a colonoscopy. That will reveal erythema, ulceration, and friable tissue perfectly isolated right at those watershed areas.
All right, let's totally shift gears now. We've covered the power supply. Now let's talk about the plumbing. What happens when the blood flow is perfectly fine, but the physical pipes get clogged? Welcome to Section 3, Mechanical Intestinal Blockages. Mechanical intestinal obstruction is exactly what it sounds like, a significant impairment or complete arrest of the passage of contents through the intestine. And it's a massive deal. It accounts for a full 20% of all emergency surgical operations for abdominal pain. The classic presentation? Crampy abdominal pain that hits in intense waves every 4 to 5 minutes as the intestine forcefully tries to push material against a closed door. Patients are going to experience severe nausea, vomiting, and obstipation. Obstipation is the absolute inability to pass stool or gas. Plus, they will become profoundly dehydrated because fluid just secretes into the blocked intestine rather than being absorbed.
Now, what's really fascinating here is exactly how these physical blockages happen. There are 4 major ways the pipes fail. First up, herniation. That's where a loop of bowel pushes through a weak spot in the abdominal wall and gets pinched off. Second, adhesions. These are sticky, fibrous bands of scar tissue that form between bowel loops. Third is volvulus, which is wild. The bowel actually twists entirely around its own mesentery, choking off both the passage of food and its own blood supply. And fourth, intercession. This is where the intestine folds and telescopes inside itself, kind of like a collapsible pointer. While all 4 of those definitely happen, they are not equally common. Breaking down the numbers highlights an absolute must-know fact. In industrialized nations, adhesions account for an overwhelming 65% of all small bowel obstructions. Let me repeat that, 65%. These fibrous bands of scar tissue almost always form secondary to a previous abdominal surgery or severe intra-abdominal inflammation. So, if you have a patient presenting with crampy abdominal pain, vomiting, and they have a surgical scar on their belly, adhesion-related small bowel obstruction needs to jump straight to the very top of your differential diagnosis. The other causes lag way behind. Hernias at 15%, tumors at 14%, and strictures, usually from Crohn's disease, coming in at about 1.5%.
To actually prove the plumbing is blocked, we have to turn to imaging. Lab tests will just show you severe dehydration and electrolyte imbalances from all the vomiting. Imaging is definitive. An initial plain X-ray will show heavily distended loops of bowel with distinct air fluid levels. But a CT scan? That is your true gold standard. A CT scan lets you see the exact transition zone. You will see massively dilated, backed-up small bowel right up to one distinct point. After that point, the distal bowel is completely collapsed because absolutely nothing can get through. Spotting that abrupt change in caliber is how you definitively diagnose a mechanical block.
Finally, we've reached our 4th section, which throws a really fascinating twist into our industrial facility metaphor. What if the blood supply is perfect and the pipes are physically wide open, but the conveyor belt just entirely stops moving? This is functional intestinal obstruction.
We usually call this paralytic ileus, or adynamic ileus. It's a temporary paralysis of the bowel that totally prevents the forward passage of intestinal contents. The intestine just fails to transmit those coordinated peristaltic waves needed to push fluid and gas along. This most commonly happens after abdominal surgery, actually following 10 to 30% of all abdominal surgeries. Clinically, it looks very different from a mechanical block. Instead of that severe colicky pain where the gut is violently fighting a blockage, an ileus presents with painless abdominal distension. And while an early mechanical block gives you hyperactive, high-pitched bowel sounds, a paralytic ileus gives you an eerie, quiet absence of bowel sounds.
The cellular mechanism behind why the gut just paralyzes itself is pretty incredible, and it unfolds in 3 distinct phases. Phase 1 is the neurologic phase. The anesthesia itself, combined with the surgical incision, activates specific presynaptic receptors that immediately halt intestinal motor activity. Phase 2 is the inflammatory phase. Just physically handling the intestines during surgery triggers a dense network of macrophages in the gut wall. These macrophages dump out nitric oxide and prostaglandins, which directly inhibit the bowel's nervous system. Finally, the resolution phase kicks in. Your parasympathetic nervous system steps up, increasing vagal tone. Cholinergic bourons release acetylcholine, which actually suppresses those inflammatory macrophages and finally stimulates the gut to wake up and start moving again.
Visually, on a scan, an ileus is striking. A normal coronal CT scan shows nice tight loops of small intestine, but in a patient with paralytic ileus, those loops become massively globally dilated. Fluid and gas are just sitting there passively collecting because the muscular tone is completely gone. Now, unlike mechanical obstructions, which very often require surgery to cut away an adhesion or fix a hernia, an ileus is generally benign. There's really no specific therapy. It just requires supportive care and time until that vagal tone reawakens the gut.
So this right here is the absolute crucial point. You have to know how to tell the difference between these two conditions on imaging because the treatments are wildly different. It comes down to one simple, highly testable observation. In a mechanical obstruction, the small bowel is dilated, sure, but because there is a physical roadblock, the large bowel downstream is completely collapsed and empty. But in paralytic ileus, the entire system is asleep. Therefore, you are going to see dilatation of both the large and the small bowel with absolutely no distinct transition point or physical roadblock visible anywhere.
Well, there you have it. We've covered the critical power failures, from sudden emboli to watershed hypoperfusion, and we've traced the plumbing backups, from sticky adhesions all the way to cellular paralysis. Your gastrointestinal tract is a complete marvel of biological engineering, but it requires this incredibly delicate, constant balance of blood supply and mechanical function. Think back to John Quidley, or the silent shutdown of a post-op ileus. The next time you sit down to eat a meal, just consider the complex machinery working silently away inside you. Now that you understand the exact weak points of this system, would you know how to identify the warning signs before your own facility shuts down? Keep learning, and I'll catch you in the next explainer.